Hi there, I'm the neuromuscular mechanic, and today we're talking about diagnostic nerve blocks for muscle spasticity. So before we discuss the blocks, it's very important to know what muscle spasticity is. And so muscle spasticity is a condition characterized by increased muscle tone and stiffness, and it can result in abnormal joint positioning and movement. And understandably, that can affect important tasks and functions such as walking, dressing. And it's something that's detectable on examination. As a clinician, we can bring it out with rapid movement or stretching of a limb. And we only see spasticity with injury to the central nervous system, so the brain, brainstem, spinal cord. And it's important to understand that not all muscle spasms are muscle spasticity. So knowing what muscle spasticity is, again, we can now look at these blocks. So DNBs, or diagnostic nerve blocks, involve the injection of a short-acting, rapid-onset anesthetic agent around peripheral nerves that are supplying spastic muscles. And what these agents do is they temporarily reduce tone and muscle spasticity if those muscles are truly spastic and the procedure is done correctly. And they do so through numerous mechanisms, including blocking the afferent signaling of motor nerves. So the signaling that comes from the muscle spindles, which is believed to be overactive and partially responsible for spasticity. And so why would that be beneficial, and why consider these blocks? So they can allow us to differentiate between spasticity and a fixed joint contracture. So if you were to do one of these blocks on somebody who has a joint contracture, you wouldn't see an improvement of range of motion, and that might suggest that other interventions like toxin therapy with botulinum toxin would not be beneficial. And again, similar thinking, these nerve blocks allow us to understand what somebody's function might look like by blocking spasticity to certain muscles, which allows us to make better informed decisions around more long-lasting treatments such as botulinum toxin, phenol neurolysis, or surgical neurectomy. So it can be very powerful tools, and there is literature that shows that these blocks can be predictive for the outcomes that we see with toxin therapy and with neurectomy. And so how do we do these blocks? So typically we inject a small volume of anesthetic around the nerves. We prefer to use lidocaine because it's short-acting, rapid onset, so we can really see the impact on tone reduction relatively quickly. Generally, the volumes are between 1 to 2 mils for each nerve that we target. And we can target different parts of the nerve. So we can target the nerve trunks. The benefit of that is that we could potentially block numerous muscles at once to see the impact on function. Or we can be more selective and block the nerve more distally as it branches into the individual muscles and be more selective that way. When we block the nerve trunks, one of the ways that we know that we're successful is that potentially we could see sensory changes. So, for example, if we block the musculocutaneous nerve proximally, we might expect sensory changes temporarily to the lateral antebrachial cutaneous nerve over the lateral forearm. We might also see reflex changes, so we might see depression in the biceps reflex from baseline. And when we do these procedures, to enhance accuracy, we can use both ultrasound and e-stimulation or electrical stimulation. And so the ultrasound, as shown in the image here on the right, this is looking at the MCN or musculocutaneous nerve, which is just to the left of the label. And so the nerves on transverse imaging sort of have this honeycomb appearance. And once we identify the nerves, we can follow them from proximal to distal, and again, depending on what muscle spasticity we're interested in temporarily blocking, we can do these procedures either more proximally or distally. Now, in some situations, the nerves aren't as easily identifiable as the MCN here on this image, but we can take advantage of our anatomy knowledge. Most times, nerves will be running with blood vessels. So, for example, the lateral pectoral nerve, it doesn't look as easily identifiable as the MCN, but it runs in a fascial plane between the pectoralis major, the pectoralis minor, with the thoracoacromial vessels. And so knowing that anatomy allows us to know where the nerves are. And then what we do is once we've identified the nerve under ultrasound, then you can advance the needle in an in-plane technique around the nerve. And once you believe you're just right at the nerve, not in the nerve, but around the nerve, you can use electrical stimulation. And you provide a very low current intensity, generally 1 milliamp or less. Now this current, if you're not near the nerve, but you're in the muscle, it won't be enough current to sort of get a contraction. But if you're right around the nerve, this low-level amplitude will trigger a contraction and will allow you to determine that you're at the right spot. And by doing this under ultrasound, you can also see the contraction and see the expected contraction. So for example, if you're trying to target the medial gastrocnemius and not the soleus, well, you can see the medial gastrocnemius contract on ultrasound where the soleus sort of remains at rest. And then when you do these procedures, again, the benefit of making sure the block is sort of short acting is that you can look at measurements before and sort of 30 minutes after the block. So you can look at spasticity measurements such as the Tardot, modified Ashworth. You can look at their strength and you can look at their function to decide, are there benefits from their blocks? So were there improvements in range of motion, Tardot measurements, modified Ashworth? Was strength similar, and were there improvements in function? Because if you see that, then that is suggestive that other interventions such as botulinum toxin, phenolneurolysis, or neurectomy may be potentially beneficial for the patient. And certainly anytime we do a procedure, there are risks, and it's important to be aware of these. So there's risks common to all injections. So infection, bleeding, bruising. Certainly the benefit of the ultrasound is that you can, by using an in-plane technique, avoid sort of or minimize that needle sort of tracking through a blood vessel, pain, injury to local structures. There's risks related to the anesthetic agent, so these could be allergic reactions or systemic effects. The concerning ones would be central nervous system toxicity, which may sort of result in headaches, dizziness, seizures, as well as the cardiovascular effects. So you might see conduction abnormalities, which can be symptomatic, potentially life-threatening. And generally, these risks are higher as you approach that max dose. So for example, lidocaine, 4.5 milligrams per kilogram. So again, be very mindful of what dose you're using. And then there are the risks related to the nerve blockade. So you might have reversible muscle weakness. This might potentially impair the individual's function over a short period. So for example, if you targeted the rectus femoris and you made it too weak, well, their knee might buckle, and if they're ambulatory, they might be at risk of falls. And as well, you might see some sensory numbness, particularly if you're doing more of the nerve trunks more proximally. And so to summarize, DNBs or diagnostic nerve blocks can be used to plan interventions for spasticity. We talked about that predictive value with botulinum toxin, for neurectomy, and for differentiating between spasticity and contracture. If you're interested in this subject, resources, papers would include French clinical guidelines for peripheral motor nerve blocks in a PRM setting. Certainly these blocks are used most commonly in Europe and particularly in France. And then a paper from a Canadian group, recommendations for ultrasound guidance for diagnostic nerve blocks for spasticity. So I plan to post videos about individual blocks, and if you have any questions, please post them in the comment box. I'm the neuromuscular mechanic, and I hope you found today's episode handy.